pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning. Welcome to the June 3rd, 2024 work session for the Shawnee County Board of County Commissioners. My name is Kevin Cook. I serve as the chair this year. Joining me today is Commissioner Aaron Mays. Good morning. Good morning. Commissioner Bill Rippon. Good morning.
Good morning.
And our county councilor, Mr. Eckert, is also here. Good morning.
Good morning.
We have a presentation to start with from TRIA Health. Angela, you'll start us off.
Sure. We have Jim Wynn here from TRIA. He'll present our annual report.
Okay.
Good morning, Commissioners. As you are aware, and I'll just kind of remind you again, TRIA Health has been a part of your health benefit that you provide to all members on your health plan. Individuals that what we're looking for, utilizing the claims data that we get through your pharmacy claims administrator as well as your medical claims. What TRIA is looking for is we're identifying through the claims as well as our outreach to your individuals that have chronic conditions who take medications to control those conditions. What TRIA does, we are clinical pharmacists who work as their advocates to help them to have a better understanding of the conditions that they've been diagnosed for, the medications that they're taking and why they're taking them. If there's any issues that they're experiencing, barriers, it could be cost, it could be that side effects, it could be just simple education on the importance of taking those medications. What our role is to be there for these individuals. We do not replace their physicians. We do not replace the pharmacies for which they get their medications. But what we are is a resource for them to be able to utilize at their convenience. By that I mean when they engage, they're aligned with their own clinical pharmacist, just like they have their own primary care physician. A couple things that give us an advantage from that side of the coin is, number one, we have the claims. So we can see all the medications that members are filling. We can see the dosage. We can see the types of medications that they're on, the combinations of medications, and so forth. The other thing is they have access back to their clinical pharmacist. By that I mean, not only do they have their scheduled appointments, they can email their pharmacist, they can text them, they can give them a call if they ever have any questions, concerns, or issues that they're dealing with. So I talk about this program being an advocacy program, and it really is, because the healthcare system is awesome, but as we all know, sometimes it's difficult to go see our specialist, our primary. Or we believe that our only resource of if we have an issue is to go to urgent care or go to the ER and so forth. And from a plan standpoint, what we're trying to do is we're trying to identify those individuals that are higher risk, more complex in your plan, who prior to coming into the program are probably costing more from a health and from a medication standpoint than those that are not, to get them well controlled. And we'll show you in the financials what we've been able to do in that arena on that, as well as just bringing back value, knowing that from an employee, a spouse, or dependent, if you're on, you have this resource, and we're always communicating what this benefit is. It's 100% free. There are no co-pays. There's no out-of-pocket cost for these individuals, and that is open to everybody on the health plan. So we try to communicate to try to engage people into the program. So what I'd like to do is just start off with the what we like to call our success stories. And these are the interactions that happen between members who engage into the TRIA program with their clinical pharmacist. And this first one is, this is where there's a dosage that was too high, duration was too long. The patient had a history of coronary artery disease, which included a heart attack. During the consult, the patient was taking what we call dual antiplatelet therapy, or DAPT, with aspirin and clopidogrel, which in that combination is a good combination, but it's only indicated to be taken for about a 12-month period of time. But this patient was still on this therapy, but yet the heart attack had been multiple years ago. It had been, so when we looked at it from a clinical standpoint, we were wondering whether or not that was going to be clinically necessary for them to be still on that medication regimen. the key here is that what we did is not only did we talk to the patient about what their physician had told them and why potentially they were on the medication, but then we did a direct outreach to the physician to alert them that the patient was still on the medications longer than we would anticipate, and was that still clinically necessary. And after talking with the physician agreed it was not clinically necessary and we wanted to get them off. So if we can get individuals off medications that they don't need to be on, we want to get them off the medications. And in this case, this is exactly what it was. But we were able to do this all over the phone, talking to the patient, talking to the physician, so they did not have to go back into the doctor's office. Didn't cost them any money, and didn't cost the plan any money in order for them to have that. So I think this is a good one, because sometimes we ask the question, how can somebody be on a medication? We have another one coming up here, almost very similar to this. How are they on these medications longer than what you would anticipate or duration would be necessary? And the reality of it is that in our healthcare system, sometimes things fall through the cracks. And that's why it's important to have oversight, have claims, being able to talk with these individuals to identify these types of situations. Any questions on that one?
I don't have any. No?
This is another one, same thing. This is a duration that was just too long. This patient had been taking ketorolac every day for arthritis pain. However, this medication is only indicated for about very short-term therapy for about 5 days. We're talking with the patient said that they've been taking it every day. And this is another one that we knew that the potential issues, as we all know, medications for the conditions that they've been designed for are really, really good. But every medication has a side effect, and they can cause other issues that potentially could be adverse to the individual. And this is just one of those ones that this medication included potential kidney damage, GI bleeds, or cardiovascular events. So now we've got a medication that they don't need to be on, but yet continually taking it, and here we have potential issues around potentially kidney damage, GI bleeds, and cardiovascular, which we know all three of those, if unfortunately an individual is to get from an individual standpoint, it's not something that anybody wants. From a plan standpoint, it's not what you want from a cost standpoint either. So these are two good, I think, examples of what our interactions are with our pharmacists, their patients, and their providers, and identifying issues that are out there. There's a lot more, but I think that we just want to give you a couple of examples of what that is. Then the other thing we're doing on this next story here is those two individuals, those two stories were engaged in TRIA. This third one, this is not an individual who's engaged. It doesn't necessarily have to be, but through the claims, what we noticed is that this individual was on insulin and also an oral medication for type 2 diabetes. What we do know is in a lot of cases that combination of insulin and the oral type 2 diabetic medications, there's not a lot of benefit to those medications. It's rare, so you want to talk with the physician. We reached out to the physician to find out if it was still necessary for them to be on this SU-DPP4 medication, and after talking with the physician, they agreed with our pharmacist, let's get them off. This is Januvia, a medication. This medication cost the plan $6,640.08 on an annual basis that we were able to get this individual off of. So hard dollar savings from that side of it. And that's what we're doing for every claim that comes through. We're looking at those claims and looking for those opportunities to find unnecessary medications and or medically there is no value associated with that. So any questions on those?
Questions? No?
When you review these, who does the review? Is it a doctor, a pharmacist, or?
They are PharmDs.
Okay.
They are PharmDs. They are the pharmacists. All of our pharmacists who work with your members are PharmDs. So the next slide here this is on the financials. So we'll walk through the financials. We detail it out. There are 5 buckets that we report on. Just at the very top there, you can see that the county invested $46,410, and the annualized savings was $366,627 in that regard. The first bucket, the green one, this is your RX savings. These are your hard dollar savings that are validated through the claims. So when you look at the first three lines, the PAP, that stands for Pharmacy Advocacy Program. Those are the members that are engaged into the program, talking with the pharmacist. And then the ones below that are everybody else that's on your plan that we're doing oversight on. So as you can see, and I won't go through all of these, but on the third one, discontinued medications for those that are actively participating in the program, we found 36 medications that were no longer medically necessary. We also got the physician approval to discontinue those. We got them off the plan, which saved them $32,648 in hard dollar savings there. I mentioned this in the success story. We also found 4 medications that aligned with that DPP-4 or the GLP-1 discontinuation. Those are expensive medications, as you can see. We had 4 instances where we were able to discontinue those medications, and those 4 cost $21,261. So as you can see, as we go through all the other ones, the duplicate therapies, we had 10 diabetes medications that we were able to discontinue, 96 PPI drug discontinuations. Those are your acid reflux medications. So in all, we were able to show $86,612 in hard dollar savings to the investment that you made in $46,410. To the right there, on the aggregate savings, the program has been in place since, I believe it's 2017, and we've been able to, hard dollar savings alone, we've been able to bring just under $400,000 in hard dollar savings in that bucket as well. Any questions on that one?
Nope.
The next bucket, this is where we're doing our clinical monitoring. These are for your diabetic and hypertension individuals, your more high-risk individuals. What we're looking for are those individuals that are not potentially meeting HEDIS measurements, potentially looking to get the reduction in A1C and or lowering of their blood pressure. We had 5 instances where we had 1-point reductions in A1C, and we had 4 where we had a 10 millimeter reduction in systolic pressure for those individuals. And again, that's what we're looking for. We're looking for these individuals that potentially are trending towards more issues around the conditions that they have and bring them back to where they're well controlled. We've got oversight on them. Now they become less of a financial risk to the plan, but more importantly, I think they themselves as an individual have a better controlled condition. And so we were able to show $20,239 in savings there. The healthcare savings, this is, again, going back to the success stories, the interventions between our pharmacists, their patients, and the physicians without them having to utilize these services. So you'll notice that we didn't give ourselves one credit for an individual who potentially, had we not intervened, would have had to gone to the ER. But we did have 14 that either they utilized the urgent care previously and were still having the issue, or in talking with them, identify something that they were unaware of, we would have asked them, hey, based off of our conversation, would you have gone to urgent care, your primary, a specialist? If they tell us, then we'll give ourselves credit there. So showing total health care savings, $14,087. And then the final bucket here are the compliance savings. This one is more of the softer dollars, and that's readily acknowledged, but I will tell you this is why you brought the program on, because this is getting individuals to engage in the program that when they come in are not well controlled. They are not potentially meeting their HEDIS measurements. They're not potentially taking their medications in a timely or taking their medications at all, or there's issues in what we call their gaps in care and so forth. So in this reporting period, we had 8 asthmatic individuals who were what we would consider more at risk, who now are well controlled. We had 10 diabetic, I said 18, I'm sorry, put my glasses on. 18 diabetics that were out of range that now are back in range. 7 with heart disease, 23 with high blood pressure, and 18 with high cholesterol. For the current year savings at $245,689. Again, those are softer, but what we do know is that if you have an uncontrolled diabetic, or if you have an uncontrolled individual with hypertension, and those individuals have an episode, the potential claims costs associated with them potentially go into your high cost claimants, and that's what we're trying to avoid. Any questions on those?
I don't. Thank you.
So this is just a breakout of the individuals that are engaged into the program. As of this reporting, we had 128 individuals engaged. And just as a reminder, the criteria that we're looking for initially is individuals that have one or more of these conditions in the bar graph, taking 4 or more prescription medications. So these individuals met that criteria. Everybody else on your plan that meets that criteria, we are reaching out to them as well. And just to give you an idea, that based off of that, we still have 335 individuals that meet the criteria of one or more conditions, 4 or more medications that we are continuously trying to outreach to. Based off of percentage-wise, that is, we have 28% of the identified individuals participating in the program, which you're about 8% higher than what our average is. So we do really well, but I think it's also the fact that Angela and Mike and the team have done a really good job helping us to promote this program, and people are gravitating towards it and will continue to do that. Now the breakdown here, I told you that we're looking for 4 or more. This is the average breakdown of the individuals. The average individual takes 9 prescription medications a day, plus 1 to 2 over the counter. They're dealing with 6 to 7 what we call chronic, non-chronic conditions. And out of that, though, they're averaging 2 to 3 are chronic out of the 6 to 7. And on average, we find about 1 drug therapy problem per consultation with their patients. So again, these are your higher risk individuals, more complex, more medications. The more oversight, the better served they are. This is a breakout of the individuals that are engaged. So you have 76 individuals out of the 128 have high blood pressure. You have 65 that are on pain medication, 67 with high cholesterol, 64 with mental health, and 45 diabetes and so forth. So as you can see, these numbers versus the number of people we have engaged, you can see why we're dealing with people on average about 2 to 3 chronic conditions in that regard. The last total drug therapy problems, these are the most common ones that we find: adverse drug reactions, compliance, just not taking their medications when they should be taking them, dosage too high, too low, unnecessary, and needs additional drug therapy. So we're always looking for those type of things that are preventing these individuals from getting to where they need to be, and then working with them and their physicians to get them back. This is just a breakdown of your diabetes management folks, those that are engaged in the program. Out of those that are in the program, we have almost 77% are what we call well-controlled. We do have about 15% that are at risk and 9% that are poor controlled. The good news is that the poor controlled and at risk, they're in the program. So as of this reporting, they had not gotten to where we need them to be, but we're going to get them there. Same with the blood pressure management. We have 12 individuals using our hypertension cuff, but overall, because for those that we're not getting the readings on from the cuff and the diabetes, those are real-time readings. We see them every day, every time they do a reading. Those individuals that don't choose to have one, or maybe don't necessarily need one, we have to rely on them to tell us what those readings are. So we have a really good idea of those that are utilizing the devices of what these numbers are. For those, it's just like we do when we go to our doctor's office. We tell them, and then they take their measurements. So doing really well in that regard from those individuals as well. Any questions on this?
Questions? No? All right.
And then the final one here is, again, we're looking at everybody on your plan. We're always looking for those opportunities, what we call affordable med. High-costing medications where there are clinically appropriate, lower-costing alternatives available to them that we could talk to the patient and the physician. You only have 14, which tells me your plan design is really, really well designed. 14 for a group this size, I don't see it that low. And probably the 14, if I looked into them, they probably are all medically necessary. But we are doing outreach on that. We did not have any med safety alerts. This is when we see 2 medications been prescribed that cannot be taken in combination with each other. We reach directly out to the prescribing physicians to alert them. We do have what we call clinical alerts, just where we identify through the claims where there are potential gaps in care. We had 55 of them, and through that, those individuals, we had 3 resolutions with cardiovascular that should have been on a statin that were not. We had 10 diabetics that should have been on a statin that were not, and we had 4 individuals filling their emergency inhaler rather than being on their maintenance medications as well. So, and then We got 39 phone calls, we promote the help desk. These are individuals, again, not engaged in the program, who just called to ask medication-related questions. Maybe the side effect, do I have a lower costing option? Any medication-related question they can ask. We answered the phone live, and we had 39 of those calls in this calendar year as well. So, and that is, yes, then the definitions are all on the last page there. Any questions for me?
Questions?
No.
No? All right.
Thank you.
Thank you very much. I
Thank you.
appreciate your time. Have a great day.
Okay. Our second presentation is regarding the homeless initiative and just feedback of where we're at, and I'm going to turn it over to Ashley Biggert, Assistant County Counselor.
Thank you. I believe Stephanie's getting the PowerPoint pulled up. All right. Good morning, Ashley Biegert, Assistant County Counselor. As you are all aware, in July of 2023, the City of Topeka engaged Silver Consulting to help address the homelessness issue within our community. And with that, the Homeless Initiative was formed. Myself, along with several individuals who have relevant credentials related to this issue, comprised this initiative, and Brianna Silver, who is the founder and president of Silver Consulting, was our design coach. As Commissioner Cook indicated, I'm here this morning to give you an update on the tasks, process, and findings of the group. This presentation that I'm about to give to you was presented to the Topeka City Council on May 21st of this year. It has just a few tweaks, which I will indicate as we go along. Since that time, the annual point-in-time count has been published, which, given the increase in homelessness within our community, really emphasizes the call of this initiative. So what was the call of our initiative? The focus of our charge was to come up with a proposal to decrease homelessness by promoting a safe and unified community that addresses the complexities of homelessness through community education and using data-driven approaches that increase the accessibility of housing and transformational services in our community. Two teams led the initiative. The core team in the left-hand column on your screen was really responsible for the day-to-day operations, and the auxiliary team on the right-hand side were the advisory group to the team, sort of a sounding board for the core group. And several of the individuals that are listed on your screen are here today, and I might just ask them to stand. If you were on the core team or the auxiliary team, could you please stand for the commission? A lot of these individuals are here past the date of our assigned charge, which I think really speaks loudly of the commitment and drive of this group to addressing this topic. It was a broad group of individuals with various backgrounds and experts in this field. Now, while these two groups were the main teams assigned to the initiative, it's important to note that nearly 200 people were engaged over the course of this process to give their point of view through the initiative. The path to innovation methodology is what guided the work. There's 3 phases of that. The first phase is really understanding the problem, which is what we spent from September 2023 through the end of 2023 doing. Next was generating and testing new ideas, which took us from January to April, and then finally the delivery phase, which is where we were at now. I'll go into each one of these briefly in a little bit more detail. With the understanding the problem phase, really the goal in that phase was for the group to fall in love with the problem. This was a little tricky for a lot of us because several of us wanted to jump straight to the solutions. We all had lots of ideas in mind. But it became clear throughout the process that this was really an important step to take first. We engaged 30 experts that included those experiencing homelessness themselves, agencies supporting people experiencing homelessness, and then those folks in the public health and safety realm in Shawnee County. We also completed several literature reviews. In speaking with the experts, we mapped out what we wanted to learn from each of those stakeholders. And then after all the interviews and feedback, we externalized that for the group to consider. In the generate phase, after understanding the problem, that led to 7 different insight statements, which became the foundation of 4 ideation sessions that took place in January. We had, in those ideation sessions, the first one was with the members of the core and auxiliary teams themselves, then members of the general public, which included agencies supporting homelessness, and then individuals experiencing homelessness, and then of course the 3 of you along with multiple members of the Topeka City Council. Over 140 ideas were generated. There were more than that, but 140 unique ideas were generated, and the team then reviewed those to determine which were best suitable for the Topeka community. With that, so one of the key deliverables for this team was to come back with a portfolio of ideas, and that is what is represented here on your screen. This is the entire portfolio of ideas with the 9 that jumped to the top. The first 7 listed here are, in the team's opinion, the ones that should get the most immediate push, and the top 2 are the most critical, which we will expand upon in this presentation. So, first is the One-Stop Shop Homeless Resource Center. Next is the investment in the continuum of housing, specifically a low-barrier shelter and a permanent tiny home village. In addition to that, we have a multi-sector community coalition that is being recommended. Transportation service is number 4. This is for when public transit is gapped. There's also a call to double down on programs and services that are working in our community, using grant writers to support channeling more money to those programs. Housing and employment second chance offerings, creation of a centralized data hub that would support data-driven decisions. And then later down the road, 8 and 9, workplace connections, which would include job matches between people experiencing homelessness and employers in our community, and then landlord incentives for second chances. Now, 60 community members from a wide range of expertise were engaged in the prototype and testing phase of these top 2 ideas, the resource center and the continuum of housing. This included people experiencing homeless, again, mainstream health services, allied health services, public safety and housing organizations, food and clothing programs, and development support. We spent multiple hours with these individuals, showing sort of a vision and concept that we had put together for these top 2 ideas, and then gaining their feedback for what they thought would work, what's not going to work, where the gaps are, etc. That led us to the delivery phase, which is where we are at now. So this phase, we have plans that have taken shape, very preliminary plans that have taken shape for the One-Stop Homeless Resource Center, as well as the investment in the continuum of housing solution. We'll now take a deep dive into the One-Stop Homeless Resource Center. So the intent of this resource center is that it would centralize all the essential services supporting individuals experiencing homelessness within a single designated location within the city. It is valuable because it is expected to accelerate the pathway to stabilization for those experiencing homelessness by streamlining and simplifying the process and putting it all in one easily accessible location. As you'll see on your screen, there are a number of services that are expected to be offered at this location. Basic necessities, food, clothing, health services in terms of behavioral, physical, and dental health, shelter and housing services, employment services, legal guidance, etc. As the team and our community put together this vision, it became clear that there were really 2 tracks. There's a long-term vision that would be the ideal, but we also developed a short-term vision that would really, we think, could get off the ground quite quickly. So that's broken up on your screen here. In the long term, ideally, this resource center would operate Monday through Saturday from 7 a.m. to 6 p.m. In the short term, however, in order to get it up and going, we think that 3 days a week from 9 to 3 p.m. would be where things should start. No appointment would be required in order to come to the center. Appointments have been shown to be quite a barrier for people experiencing homelessness in order to get access to the services that they need in a timely manner. The support that would be offered would include a dedicated navigator. This is likely the key component of this entire resource center, is having this navigator and that would go through the process with these individuals from beginning, middle, and end, really helping them along the way and meeting them where they are. As far as the engagement, it would be expected that there would be frequent engagement by individuals. There would not be a cap on the number of times you could visit the resource center. Partner agencies. So in the short term, partner agencies would be physically located at the center and would provide that support only when they are physically located there. And they may not have a dedicated space within the center, because if we're only operating 3 days a week, the other 2 days of the week, this center is going to be, or this location is probably going to be used for a different use. But in the long term, the partner agencies would occupy dedicated spaces and have the ability to engage virtually with individuals at the center when they can't physically be there. Who will be served? It would be designed to cater to the individuals who meet the federal definition of homelessness, either using the HUD definition or the McKinney-Vento definition. However, with that said, we also believe that this could touch those individuals who may be on the verge of homelessness, to prevent them from getting into that state of homelessness altogether. Now, design standards are going to have to be kept in mind to account for the various types of people that are going to be accessing this center. You're going to have families, you're going to have people who are just exiting incarceration. It's going to include veterans, folks who have victims of sexual exploitation, adults with sex crimes. So you're going to have to keep all of that in mind in establishing the space and designing the space. As far as the location, in the long term, the group believes that a campus vision is what would really be necessary. In the short term, however, a freestanding space that would accommodate the operational needs of 2 programs within our community that we know are currently working well, Impact Avenues and the Mobile Access Partnership. Whoops. Yes, okay. So what does establishing this resource center look like? I will note that this timeline has been amended slightly since the presentation to City Council last month, in order to give the incoming city manager, who starts later this month, time to get up to speed when he begins. From July through September of this year, the goal is really to define the location for the resource center that would again accommodate MAP and Impact, and even I know SENT is doing a lot of things along these lines. So a space that would accommodate all these groups that are currently doing resource offerings in various ways. Then through October of this year, we'd be defining the staffing and the logistics. So defining which partner agencies want to be a part of the center and when, and then really establishing who's going to provide those navigation services that are so key to the success of the center. And then by mid-November 2024, the ideal would be that the center would be open for operation. Next year, the center will have been open 3 days a week with no appointment required over 3 seasons. So for winter, spring, and summer is when the resource center would be open by the end of August 2025. And so at that time, we'd really be assessing what about the center is working, what needs changed, and then assess whether or not the center needs to expand, more hours, maybe a campus-style location being looked at. So really, this initial time frame would be to kind of pilot the program and see if the bigger vision can be achieved or needs to be achieved, or if what's happening currently is sufficient. So these ideas are great, but how are we going to measure whether or not they're working? We put together sort of a tracking system to determine what we'd be looking at in order to determine whether or not it's having the desired impact. So if you'll see in the output column there, and we'd be looking at the total number of people served, including, unique people versus repeat visits. In terms of the service reach of the center, be looking at the number of people attending and utilizing services, the number of people served by each partner agency compared to prior years. This would obviously be key when you bring everyone together to determine whether or not having that centralized location is having the desired impact. The percentage of services accessed that were recommended to an individual and over what span of time, how many services are they accessing at the resource center? And then the number of people who have gained access to a city ID. We look at how things are going in the first 6 months, and the hypothesis is that people are going to be utilizing more services that will then accelerate their path to stabilization. So this would be a test as to whether or not that is happening. Look at the increase in the number of people with a stable income, the increase in the number of people who are housed, the increase in graduation rates and school grades of students experiencing homelessness. And then we'd also be looking at scores on the engagement survey for folks who are accessing the center. As far as impacts to health, public health and safety, we would expect a fewer number of ambulance calls, fewer number of ER visits, and more co-responder CIT calls. The impacts, ultimately, what we'd be looking for is achieving what our focus statement was in the very beginning, which is decreasing homelessness within the community, of course, and creating a more safe and unified community that addresses all the complexities of homelessness. So that covers the Homeless Resource Center and brings us to the investment in a continuum of housing solution, and specifically a low barrier shelter and permanent tiny home village. How did we get to these two types of housing? First, the team came up with a housing continuum and created basically what an ideal continuum for the community would look like in an ideal world with all the money there could be. And they put forth this continuum. There's different stages throughout the continuum. The first one is the entry point, which has two pieces. One is the initial engagement phase, and the second one is the connected engagement phase. In the initial engagement phase, this is folks who are experiencing homelessness but not yet willing to accept services and not really willing to move beyond where they're at right now. This is where the low barrier shelter would appear on the continuum. Connected engagement is those folks who are willing but not necessarily committed yet. The community-based transitional housing phase is those folks who are a little more committed. And then in the 12-month stabilization and after phase, that's permanent housing in some form. So this is where the permanent tiny home village appears in the continuum. We took this continuum to the members of the community, including people experiencing homelessness, again, a development group who have experience with housing developments, agencies supporting homelessness, and they were given a voting system with an allocation of points to kind of determine where the gaps were and what was the most needed in our community at this time. And that's where the low barrier shelter and the tiny home village became apparent that those were the most immediate needs. Now, it was very clear in the conversations with these individuals that while local government has a role in supporting these housing continuums, it should not operate it, should not be in the business of owning and operating it. Once people voted, there was deeper conversation about what a low barrier shelter looks like, what a permanent tiny home village looks like. Now they can take many forms, and there's many different kinds of low barrier shelter and different ways to operate it. What you see in the left-hand column for the low barrier shelter here is a starting point. These are the key factors that the team believes should be included, although more specifics are going to need to be identified in the future. So what it would look like is that it would include both congregate and non-congregate forms of a shelter. It would be built to include different levels of incentives for those folks who commit to support, It must accommodate pets. This was a huge sticking point. It would be secured and weapon-free and include community education about what exactly it is. For the permanent tiny home village, it would be a village initially of 8 tiny homes constructed within a community near a transit line. Now, 8 tiny homes is not going to fix the homelessness problem in this community, of course. But this, again, would be sort of a pilot to determine whether or not it works and is addressing a need and whether it needs to expand in the future. Each tiny home would include a kitchen and bathroom. Case management would be offered in the way of peer mentorship, and people living in the community could be hired to take care of the community. This was an idea of homeless individuals that are interviewed themselves, really wanted to have ownership in the community that they lived in. Housing would have to be zoned to be affordable based on a percentage of an individual's income, and it would support development models that promote safe, affordable, and decent permanent housing that would potentially include ownership. So the implementation timeline would be similar for both the tiny home village as well as the low barrier shelter. And what that looks like, again, these timelines have been somewhat amended in order to account for the city's request to extend them out a couple of months. So you'll also note through these timelines that a lot of these actions are intended to sort of take place simultaneously through the end of 2024. But from July through November, the idea would be to gain public support, really introduce the community to these ideas of a low barrier shelter and permanent tiny home village. And then also at the beginning of July, there would need to be a system for collecting information on the interested parties for these 2 housing options. We'd bring together those interested parties to formulate an education campaign, again, for the public to become supportive of these concepts. Again, through the end of the year, there would be research done on best practices. What does a low barrier shelter in this community look like in addition to those key factors that I already described? And then, of course, there would need to be alignment with policymakers on the best structure for each housing solution. Beginning next year in 2025, funding and location would need to be identified for both the low barrier shelter and the permanent tiny home village. And then there's a hope that by mid-2025, we'll be settling on who's gonna operate these structures. That would take place, of course, using an RFP or RFQ process in order to determine who's going to operate them. By the end of 2025, although we've identified the funds and location at this time, we'd be securing those funds and location. And then by 2026, crafting the development plan for each structure. By Q3 2026 and Q1 of 2027, construction of the low barrier shelter will have begun. And by the last quarter of 2026, the installation of the first phase of those 8 tiny homes will have been underway. And then the goal is that by Q1 of 2027, the first permanent tiny home village would be opened, and by Q2 of 2027, the low barrier shelter will be opened. And at that time, thereafter, we would assess the next steps in terms of expanding that permanent tiny home village to other areas of the city. Okay, so the impact measurement plan, similar to what we looked at for the Homeless Resource Center, we have to look at how we're going to measure whether or not these 2 housing options are successful. And that plan looks a little bit different for the low barrier shelter versus the permanent tiny home village. So when the shelter opens, the low barrier shelter will want to understand the total number of people who are using those entry point shelters. And then the number of unique people served versus repeat visits. And then the capacity. Is it operating full capacity, or what is that looking like? We'll also want to measure the number of people that are exposed to the community education campaign in order to determine whether or not we're really getting the message out there about what this looks like. In the outcomes, the goal is not to have people in the low barrier shelter forever. It's to create a relationship with people and create a willingness to participate in these individual stabilization. The number of people who attended the shelter and also engaged in the one-stop shop resource center would be looked at. The number of people who accessed services and a reduction in the number of days that individuals have been living outdoors. And then again, we'll be looking for an increase in community support. And these impact measures, again, reflect directly back to the focus statement of this group that we took on in the very beginning. As far as the impact of the permanent tiny home village, in order to determine its success, we'd be looking at the capacity of the village and the number of people on the wait list, if there is one, what the family makeup is of the people occupying that village, and the commitment and engagement of the folks living there. So the number of days they live there and the number of residents that choose to actually work in the tiny home village. We're looking at the projection on the number of structures that might be needed in the community, and assuming there is a decision to increase that, we would hope to see an increase in affordable housing within this community. In order to increase stabilization, we'd be looking at the percentage of people living in the permanent tiny home village that have been able to consistently pay their rent on time, and then increased feelings of belonging among those folks. So those are the three really major plans that the Homeless Initiative group developed. And as a result of that, there were 2 asks that were submitted to the City Council on behalf of the team. And it was support for these concepts of the One-Stop Homeless Resource Center, the low barrier shelter, and the permanent tiny homes. And then the official chartering of that multi-sector community coalition that would really lead the charge on these actions. Ultimately, the City Council did not take official vote on supporting these endeavors. However, several of the members expressed their individual support. And the unofficial consensus seemed to be that they wanted some additional time to digest what the group came up with, discuss it with interested parties, and also, again, account for the incoming city manager later this month. With that, I'm tired of listening to myself speak, so I can only imagine where you are at. I will stand for any questions, and again, the folks from the teams are also present to answer any questions you might have.
Questions for Ashley or the team?
Ashley, how many kids did you find that were in a homeless situation?
Kids, did they find? Are you talking about in the point in time count?
Yes.
It appears there were 73 people under the age of 18.
Was there any talk about moving those kids to a more stable situation?
As far as the point in time count, I can't necessarily speak to that. I believe Ms. Higgins is here, and she certainly can, or Ms. Boyles. So I might ask them to come up and address that.
Good morning, Carrie Higgins with the City of Topeka Housing Services Director. Of those children that we counted through the point in time, none of those were unsheltered. They were all either in some sort of transitional housing or at a rescue mission.
All right, thank you.
You're welcome.
Commissioner Mays?
Great presentation, very thorough. I guess I probably would perhaps ask some of the folks, is there anything that needs to be said that wasn't already said? That I'm sure there's we could dive as deep as we want to into this probably. I know, I think all of us took part in the little workshop up at the Great Overland Station, and I think that was pretty valuable for me at least. And so, I mean, is there anyone else that has stuff to add to this, or?
Before we get to that, though, Ashley, maybe this ties into it.
Mr. Chairman.
Yeah, this ties into it. Take the demographics from the point in time count. And one of the demographics that's jumping out to me is this year, that point in time, and again, this is just on that day, this may be higher, may be lower on any other given day, but on that day, there were 537 people. If we were to go back to 2021, we were at 298. And so if we look at the difference between 298 to 2024, or sorry, from 2021 to 2024, in that 3-year time frame, it came close to almost doubling. So if you go back 2 points on your slide, we can. One more, sorry. There we go, time frame, right here. If we are looking at a timeline of the first tiny home, low barrier, both of those in the first quarter of 2027, that's 2.5 years from now. And if we continue on the same trajectory, which it may or may not, I mean, not all things are constant, things can change, are we going to be severely, it looks like a very small impact in which we may be looking at 700 people, again, if those numbers and trends continue. And I didn't know if the homeless initiative kind of took that into account, that we have a blossoming number, and is this going to be sufficient 2 years from now when we finally have the low barrier shelter up and running and the other things? Is this going to be too late, too little too late?
Certainly, that's a good question. You know, I will note that at the time, this point in time count occurred at the end of our initiative, and so we didn't have these numbers. But it's clear that regardless, the number has been steadily increasing year after year. And I understand that the timeline related to the housing initiatives seem to be far out. The hope is that, though, with that homeless resource center, that we really feel like can be up and running by the end of this year, that will really drive down that number. That is the hope, of course, that is the goal. And as far as the housing timeline, certainly if that can be shortened in any way possible, you know, that should absolutely be looked at. This was trying to take into account, you know, there's going to be all sorts of zoning and policy decisions that need to be made to accommodate a tiny home village and likely a low barrier shelter. And then of course, having a third party run it, having the navigation with that piece, with that, that's all going to require time and process. And so Q1 2028, is that ideal? No, it's not ideal. But it is sort of worst case scenario goal, I suppose. And if anyone else wants to speak to that, I'd be glad.
I want to kind of address Commissioner Mays first. Thank you for just listening, all of you, but also asking, is there anything else we need to add? And, you know, I think just as the executive director at the rescue mission, my ask is that whatever we do moving forward, that there's not just one entity making the decisions, that it is something where we are collectively doing it as a community. This is not a Topeka rescue mission concern only. It's not just a city of Topeka or a county only. So I think if we really want to make a difference and be pioneers in this and be examples of what effective housing can look like, compassionate approaches, and to build a thriving community, I think we're going to have to start doing it by mixing nonprofit, faith, government, and really creating authentic partnerships for moving forward. I think my other ask or just expression that I feel like needs to be said is that we have to find the balance of what to do now and what needs to be long-term. So to kind of pivot into Commissioner Cook's question that he asked, do I think that we should be waiting that long for the housing piece? Absolutely not. But what I also ask as the executive director of the Topeka Rescue Mission is that we don't make knee-jerk reactions that are not informed, because sometimes we are trying to put a Band-Aid on something, whether it's to make constituents feel like we're moving forward or some type of political move. And what I would just ask is that we take all of the research that's been done with this new consultant approach, also take an effect past experience and what has been done and what has been trying to be presented on moving forward, and that we do it together in a timeline that makes sense. For example, you know, an ordinance and different things that can impact, those have to be done in a phased-in approach. So these housing approaches, we can't just build something massive and not have the logistics behind why we're doing it, how we're going to do it. So anytime we can take this part of what we're needing to do for the housing and put it into phased approaches, I think it's going to be effective. And I think that we could begin additional phases of the housing portion to this sooner than what we even have mapped out if we're doing it logically, systematically, and together. I don't know if I'm allowed to do this, but I also think that it's important for Barry Feaker to address that question, just because if you remember, he did present to the city council back, I believe, in 2021, urging us to do something because of the rapidly increasing numbers. And so I think that it would be valuable for our community to hear from his expertise about what it could look like in the next 2 years and what we should possibly be doing.
Thank you, Lamanda, and thank you, commissioners. This is a very complex deck of cards across the nation as well as here, and I think that when this deck goes up in the air, it can scatter all over the place and be very disjointed, and we'll probably get the results of a disjointed approach. What we've got to do, and it's already been addressed here and it's been recommended, that we need to have as many people that understand this issue in a multi-sector approach to be able to come together. Because you can get this information, the city has this information, but what now? What do we do next? I do believe, because of what we've seen in this community already, that there is a will to do things well, there's a will to do things right, and we can expedite things to move forward. There have been previous plans that have been put on the table historically, about 3 years ago. They were not accepted at the city level. Now it's time to revisit those plans, and part of those plans are what we're talking about here today. It will take heavy investment. The issue of homelessness, chronic homelessness especially, is one that we didn't create. It's been created over a period of time. Commissioner Cook, you're exactly right. We have seen an exponential growth here. We're going to see a continued growth. Statistics nationally are going to bear that out. We saw that post-pandemic. We talked about it, and here we are. So we can't wait forever, or we're going to have other issues of community health, community safety, and just human suffering. So I believe that we have some things in place that are post this report that we can take to the next level, and those will be explained to you at some point in the future about the details of that, but I think that we need to move fast.
Right. Thank
Questions?
you. No, thank you. Thank you, Gary.
Commissioners, good morning. Bill, Persinger.
Come on up, Bill. They can't hear you.
Wasn't going to stay that long, Commissioner. Make it quick. Commissioners, Bill Persinger with Vallejo Behavioral Health Care, and a great partnership here. The only comment I want to make is the one I made to the City Commission, is that the unique thing about the proposal and the work and the process, and indeed the work that went on, long before this group was formed, is not so much the ideas that we came up with that many people have talked about, was that the unique thing about Topeka and Shawnee County is the partnership. The faith-based partnership, our JUMP partners have been active all the way, your nonprofits have been in there, and government. And so that combination, that powerful base of people, and also commercial enterprises, that may be represented and have been represented all along, or just make this a very unique thing. That's the only comment I want to make, other than thank you for your time.
Thank you.
Ashley did a great job, by the way.
Thank you, Bill. Rihanna, can I call on you for just a minute? Sorry. Can I put you on the spot? If we're talking about the low barrier shelters or tiny homes, are those currently within city code now, or is this going to be a new area that the city's going to need to tackle for code compliance and code creation?
Yeah, so I will say the zoning probably poses the largest challenge. The building code, when we adopted the most updated international building code, there is a piece of it that talks about tiny homes. However, it's it's all about translation. We just need to start putting something on paper and seeing what it looks like to see how far we'd be deviating from what we currently have. But I think it's possible, just a process, but.
Okay, so part of this process of getting this up and running is also going to be going through the city code and coming into, bringing that into compliance with or in alignment with, right?
Absolutely.
Okay, all right, thank you. Commissioner Mays?
While you're up there.
Sure.
So I guess, you know, obviously we need to figure out like why these people are homeless. Obviously we have a housing problem. This is, I think, from 21 to now, I mean, like probably a 40% increase in homelessness, but our population has not really grown by that or anywhere near it. And it seems like part of it is that we're not having any new housing built, at least not any multifamily that might accommodate folks. So how many of these people do you know, like, are homeless because they either can't find a place, or maybe they've been evicted before and they can't pass a background check, and then, do you know any of this stuff, or, okay, yeah.
Yeah, so speaking to the details of that, I would probably let Carrie and Housing Services pull on that a little bit, but I think talking about the broader picture of the development side, we have started to see more developers that are targeting LIHTC housing credits come through KHRC. One was just awarded a project in downtown Topeka, so we know that affordable housing complex will be developed there in the next year and a half. So we are getting more looks. I think Topeka has always probably had a struggle with attracting new developers from outside to come in. We have a really homegrown approach to development and a lot of single-family housing. So this is something new that we're targeting and trying to attract, but I think we're seeing that starting to catch on. So we'll see some new affordable housing come online soon.
Thank you.
But as far as the details of the individuals, I'll have to let Carrie answer that.
Okay.
Hello. There are a multitude of different contributing factors. Lack of affordable housing is certainly one of those. Lack of what I call second chance landlords for those that do have prior evictions or maybe felonies on their record. And then the other piece of it that ties into the one-stop shop is if you are in crisis and you're homeless and you are just trying to get through the day and figure out where you're going to sleep and how you're going to eat, trying to navigate our systems is completely overwhelming. And so having that one-stop shop, having those navigators that can come alongside them and assist them with all the other contributing factors can make a huge difference. We have done a very similar approach with Impact Avenues that has been very successful.
As far as some additional statistics, the Topeka Rescue Mission last year really knew that we were going to be embarking on the need for data instead of just opinion or what we're thinking. And so our street outreach team, in addition to the point in time count, now is doing surveys 4 times a year so that we can have quarterly data in addition to the point in time count. So we are about to do another data sampling in June, and that will be our 4th one. So we have an entire year's worth of data. Collected so far to date, not including this last one, is 157 individuals were surveyed. I want to really express that that is street homelessness. That is not guest in the Topeka Rescue Mission. And so when you look at the percentage of those 157 people in 3 surveys that we have surveyed, 65% are either born and raised in Topeka or have been here for 15 years or longer. When you're looking at those that are wanting to access low barrier and tiny home options because the Topeka Rescue Mission isn't an appropriate fit, or maybe they are still on the EAS wait list with the city of Topeka, 93% are wanting to access or needing to access a low barrier or a tiny home option. So that's 93% out of 157. And then when you look at, we only, out of the 3 surveys we did, we started looking at income. Who has an income that's on the streets, but they're on wait lists, because we wanted to be able to help the city of Topeka in EAS's process as well. And so the first survey, we didn't ask that, we didn't think to, we didn't know to, but then after we realized that would benefit them, the second survey and the third survey, we asked income, and 40% of those individuals had income. So the myth out here that the majority of people are choosing homelessness, it's not accurate. We have a great number that are on the wait list. We have a great number that are saying if we had another option, I wouldn't be on the streets. I would access a tiny home option or low barrier.
Thank you.
Good morning, Brian Cole, Shawnee County Department of Corrections. Oh, somebody smells. One of the things that I want to stress the importance is that if we continue the counts and things like that is we don't include the jail population in your time and count. And we have a 514 count today, and 25% are homeless. I keep the stats on SMI for all of our homeless and things like that, and probably 60% are either mentally ill or deal with drug and alcohol addiction. Probably 60% have high levels of medical problems that are a deep expense to the community. And also, the majority of these are here on low-level crimes. So, not saying that there's ever going to be a mass release from jail, but what I will tell you is that at any time, you can increase this almost 25% from those that leave the jail. And, you know, I don't have the mandate that when they leave that you have to find services. Part of our accreditation is that we do find services. The majority of those who don't know, we don't know when they're going to get out, they're just let out, and we don't have any time. So I just want to put the emphasis on that as you're going through the count, that, and I've done our count I do our count 3 times, or every quarter, and our numbers has been right at 119, 121, and 120 on 3 different days. So we're averaging 120 homeless people in jail. Now, the one thing I do have to say, some inmates may not say that they have a residence, you know, so, but the majority of those that I will talk about in the jail could not sustain employment or sustain housing because they're too sick to do it. And so that is going to be something that, as we continue this talk, that the jail serves another 25% that's unaccounted for in the community. So I just wanted to let you know.
Brian, do you know what percent of your population are from Shawnee County, or are they from other counties that happen to be?
Oh, I've done that before. The last time we did, well over 80%, well over.
From Shawnee.
Yeah, because we do hold for other counties, and we do hold federal inmates and state DOC inmates that are from other counties. But it's very high as Shawnee County, yes.
We do have a policy in Shawnee County that at an hour we stand, get a little bit of circulation so we don't all, you know, fall asleep sitting here waiting. So we're not being disrespectful, but thank you, Brian. Okay.
Just pull a hamstring.
Now, go ahead.
I was just going to add that HUD's definition of homelessness is you have to be unsheltered or like at a mission. So the homeless numbers that we have don't account for those individuals that are couch surfing. They're homeless, but they're moving maybe from household to household. So those numbers are not included in that count. And then also, I was going to mention that we will be doing a summer point-in-time count this year, just to get better data, a different time of year, and kind of keep track of our numbers a little bit better.
All right, thank you. I know that the JUMP Force Task Coalition is here. I know that we had a presentation from JUMP earlier this year. Do you want to come forward? Because you were also working on a homeless initiative. Kind of talk about maybe some thoughts and recommendations.
Hello, Commissioners. My name is Marcy Weekly, and I am representing JUMP and have some of my fellows over there. So we are here today to show support for a low-barrier shelter in Topeka, and we're excited that the findings of the Homelessness Initiative align with our own research. Homelessness is a complex issue that affects not only those without homes, but our entire community. Low-barrier shelters are a critical component in addressing the issue because they reduce the common obstacles that prevent people from seeking shelter. People need a safe place to lay their heads before they can start addressing the root issues like job loss, addiction, mental health, and so on that may have contributed to their homelessness in the first place. We are excited to work alongside the other community leaders on this issue, identifying best practices in the next few months so we know exactly what a low-barrier shelter should look like here. We're in the process of asking several community leaders to join us on a site visit to see the Avivo Village model later this summer. And we'll collaborate with all other stakeholders in order to obtain their thoughts and that when we return. We know this is a long process that is far from over. But we do hope that you, our county commissioners, what you will hear today is that we know that anytime anyone recommends more resources for the marginalized in our community, that people start coming out of the woodwork with negative feedback, and we know that you hear a lot of that. However, because we hope our presence today and the support of the 775 people who attended the Nehemiah Action Assembly on May 13th, we have our voices, but we also know that the community has meaningful, compassionate changes to the way we support our in-house neighbors. So please do not let the results of this study get pushed to the side and forgotten. We need to act now. Topeka Jump will be here supporting every step of the process to bring a low-barrier shelter with wraparound services for our community. Thank you.
So thank you. So the recommendation or output from JUMP is that a low barrier shelter would be something that would be beneficial within the community.
Correct.
Okay. All right. Thank you. Now, I know we have number of other individuals present here, and we've heard from quite a few. Is there anyone else that's wanting to add input from either the core group, the auxiliary group, or JUMP? Okay. Questions, commissioners?
Nothing I can think of now.
Okay. As with anything, I mean, I think this is a issue that we have to look at from both a county perspective and a city perspective. This is an issue that we have to look at from a budgetary standpoint and looking at the fiscal dollars. One question that I did have that remains, and actually I might call back upon you, is that you had input that this should not be owned or directed by a government entity, but by a third party.
Correct.
So is this a entity that would already be in place, or is this a new entity that would be created for this purpose?
It could be one, it could be either or.
Okay.
It really could be either or.
And so from then, at that time, does the impact from the county and the city just become more of a fiscal or financial contribution?
I think, yes, that's a component of it. Of course, there's, I don't know that it would be ongoing, but the zoning component, of course, that would require support from the city, policy decisions, ordinances, and such along those lines.
Okay, all right. Any other questions based on that? All right, well, I think this is an issue that we need to embark upon, and an issue that we need to address, and that continue to hear back from, and look forward to working forward to address. So, thank you all. We do have public comment. Is there anybody else who wishes to add any public comment?
Morning. Briefly, Henry McClure, Shawnee County. For $2,700, you can buy a shipping container. If anybody was in here June 8th, 1966, and saw what tornadoes can do to our community, you would also want to think about when you're going to build tiny homes, how you build them. And I think the challenge we've had with the community so far, dealing with planning, and it's something that you need to address, or we need to address, or I need to address, is that it's coming up with a uniform set of plans. So every time you build a home in a shipping container, you basically can build the bathroom in what would be like a safe room. No windows, steel door, block it off. And you can make some very affordable housing out of shipping containers for not a lot of money. And what it does, it also basically, you've got to figure out how to get a return on your investment for doing it, and whether it's worth your time and energy. So, sometimes, you know, what I kind of get tired of hearing, you know, we need to attract outside developers. Well, why don't you just make it easier for us to develop? When a guy like Howard Paul has $20 million He says, I can get a better return on it in communities that want to work with me. I know that it shouldn't take me 2 years to get a building permit to build a Pizza Hut. And I also know that it shouldn't be so hard to put in a Chick-fil-A and a Whataburger on the boulevard. That aside, in our last week's show, it was couched that I was picking on department heads, which is not true, because I think you've got some great department heads around here. What I was trying to frame the issue is policy. And I made the Cora request, and it's sure, I'm not blaming Rich Eckert in any way for the lack of collection of the real estate taxes out in Lawrence Bay. What I'm trying to point out is there's favoritism. A guy you just can't pick and choose what taxes you're going to pay and not pay. If they're the treasurer's duty, isn't it your responsibility to tell the treasurer to collect them? If the fallback government is the county, and lack of action for the county to not deal with the city to collect the taxes, if we have a housing shortage, think about it. Lawrence Bay, the roads are going to fail before they're ever built on. And I think it's the duty of the county to work with the city. It's as much inaction. You can't say, well, that's their responsibility. The city of Topeka is within the county of Shawnee. And if you have the power to lock us down and make us wear masks, you've got to have the power to collect the taxes from people that aren't paying. So thank you for your time. Appreciate what y'all do.
Any other public comment? Commissioner Mays?
Nothing from me.
Commissioner Rippon?
Nothing.
All right, with that, see you all on Thursday. We're adjourned.